getting some input from Dr. Sarah Woolsey in our office,
Right.
who's Mark's replacement. And we want to be careful as we set precedents for how data will be shared related to medical cannabis. And, obviously identifiable data can't be shared, but we want to be just judicious in how we move forward. And so we're wanting to, I think right now, right in our steps, we're getting some input from the Center for Health Data and Informatics on how to navigate this. We're deciding how to use that group as we respond to data requests from researchers, others for medical cannabis data. There's some resources that group has that are tried and true, and Navina, I think, has a good handle on approaching data requests for the department as people request birth and death data. And we want to be able to build on potentially some of what they've already created. So, I think Reshma and I can make sure that Jerry's given an update on where we're at, so he
That'd be great.
gets informed. We'll do that.
That'd be great. I certainly don't want to lose his interest or think that somehow, we're shining him on. Yeah, if you could just reach out, that'd be helpful.
Yeah.
I mean, I have no problem with being an intermediary of sorts to whatever I can do to be helpful, but direct connection. Well, I see Dr. Woolsey on.
Good morning, Dr. Fine.
Wonderful to see you, Sarah. Just please call me Perry, and it's wonderful to see you. I'm going to make a little special introduction as we get started here, so that you can introduce yourself to
Thank you.
the group and anybody publicly, and let us know about you. But it's delightful to see you, and
Good to see you too.
We wish Mark all the best. I guess we should all be so fortunate to work into our 70s doing things we love doing. And
yes, he's doing great from what I hear. He's not checking his email every day. So
yeah, I bet you we haven't heard the last of Mark Babbitt.
Oh no,
And I
absolutely not. Yeah. Well, nice to see you. Yeah.
Good to see you too. Reshma, when you see a quorum, just let me know, and then I'll gavel us officially to order.
Yeah, I don't see a quorum yet. I know that Karen Wilcox and Lauren Heath won't be able to make it. So we just need Dr. Red or Dr. Zender to come in. And I'll just announce that
I was just going to say, it looks like we've got a few of the pharmacists that work at the medical cannabis pharmacies in Utah who've called in, which is great.
Yeah, it's good to see their names. Reshma, could you give Ed a quick call if you have his number? He's usually an avid participant, but sometimes gets a little bit behind the 8 ball scheduling wise.
Great, I'll do that now.
Thank you.
And we've got the legislative session over with.
You must are you caught up on your sleep, Rich?
Yeah, there are people that sleep less than me during that period. As you know, there was a lot of legislation that related to COVID-19. And I know other people at the Department of Health lost more sleep than I did. But certainly that was one of the themes, is some of the legislation that related to the pandemic, I think.
I see Dr. Builder has joined us. Debbie, it's so great to see you. And
Hi, it's good to see you. I'm seeing some
thanks for your
faces here that I
willingness.
haven't in quite some time.
And well, it's so generous of you to do this with us and for us. And we're gonna get to you as quickly as possible. There's a few little formalities that we have to get through just to get the meeting started. That might take a few minutes, but we don't want to take more of you than we absolutely need. But thank you, and I'll introduce you in a moment.
Sure.
And there we got Dr. Red. So I think we do. Is that a quorum, Reshma?
Yes.
Thank you. Okay. Well, let me get started then. We're going to be a little more formal, not for any particular required reasons, only that with this first full legislative session behind us after the first year of the program, obviously there's a lot of interest in cannabis related things. There's with a number of people in the program, both recipients of the products as well as those who are recommending them, a lot more interest, and we get more people involved. I think communication and clarity as well as total transparency is all very important. So let me just, by saying that, it's going to take me a couple minutes to sort of get through some formalities here, and then we'll proceed with the substance. So just introduce myself again to anyone new. I'm Perry Fine, chairperson of the Cannabinoid Product Board, and we'll bring the meeting to order here on the 9th of March 2021 at 10:05 a.m. This meeting, of course, is being held virtually and hosted by the Department of Health, the Center for Medical Cannabis, based, of course, at the Health Department in Salt Lake. And I know we're all keeping our fingers crossed that maybe with the next 1, 2, even 3 months at the outside, we can join back together again after we're all vaccinated and so on. So I'm going to remind everybody that public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah public notice website. And in compliance with Utah's open meetings law, this meeting is being recorded. So what you say will be in perpetuity, for better or for worse. Recording of this meeting will be posted to the Utah public notice website no later than 3 business days following the meeting, and written minutes will also be prepared of this meeting. Approved minutes will be posted to the Utah public notice website no later than 3 business days after the board approval. And so I'm just going to sort of read the roll call as I see people. There's myself, obviously. I see Dr. Crookston. Mike, it's great to see you.
Thank
Dr.
you.
Ed, it's always a pleasure to see you. Dr. Wilcox has a conflict this morning, so she won't be joining us. I see Dr. Carlson, Catherine, Katie, it's always a joy. And Lauren Heath also has a conflict. And hopefully maybe Dr. Zender will be joining us later. So we have some special guests that we're going to be with us this morning, but there are some of our regulars. Rich Oborn, as you see on the screen, is the executive director of the Center for Medical Cannabis, and he will be joining us at all meetings. And Reshma Arrington is our epidemiologist, and we've sort of made her our factotum of jack of all trades to support our program, and she's absolutely marvelous. Still, I don't know, she's been camping down at that arch for a long time, and it looks still. Reshma, we hope you come back soon. Dave McKnight will sometimes be joining us, and we have a new member of or person who will be joining this group from the Department of Health, Dr. Sarah Woolsey, who is stepping into the very big shoes of Dr. Mark Babbitts, who after, I don't know, 113 years has finally decided to retire. But as I told Sarah, I suspect we'll be seeing and hearing more from him. He's very interested and involved and engaged, and too much wisdom and knowledge to let him sit in the background. So maybe we can get him involved in other ways. But Dr. Woolsey, I'd like to take this opportunity to really let you introduce yourself. Tell us a bit about you, and then we'll proceed.
Yeah. Hey, thank you so much. And agree, Mark Babbitts actually been a mentor of mine since '97 when I was a family medicine resident at the university. So really respect and have admired his career. So I'll let him know what you guys, nice things you said. So I'm a family physician. I came to the Department of Health just 2 weeks ago from CoMagine Health, which is a nonprofit that works with Medicare quality. And have had an interest in particularly opioid use disorder safety. So did work with the Department of Health on that, educating clinicians. So that's one of the sort of peripheral touch points to this particular topic. I am newly a QMP and taking on the education. I got to see you, Dr. Fine, in your really good cannabis education that the university put on. So appreciate the knowledge and the energy behind that. And I've been practicing physician in this Rose Park neighborhood 20 years with the federally qualified health centers, have also been a volunteer at the Malahi Clinic, and then most recently did home-based care. And then at CoMagine Health, acted in all steads related to quality and engagement of medical providers of all sorts. So coming to the Department of Health for me is coming back home to women's health, which Medicare doesn't have as much of that. So very excited to be in this division, and then just delighted to meet Rich and Reshma and the team that is from the ground up putting together the medical cannabis program. And I'm committed to our medical cannabis mission, to furthering my own education, and I will be leaning on Mark at times for his wisdom and expertise. So thank you for the warm welcome, and nice to see so many of you.
Mark, please assure me I'm not hallucinating. That's not the ghost of Dr. Babbitts. Mark, thanks for joining us in this little transition. We were just wishing you well, and I see balloons behind you. It's either somebody's birthday or you threw yourself a big party.
That was for retirement.
Well, I doubt you don't look like you're retiring, nor shy. Anyway, it's good. It's great to see you. And I told the group we're going to do everything we can to take full advantage of you, your wisdom and your knowledge. So we've got your phone number and we know how to use it.
I can only stay with you today till 10. I have a physical therapy appointment at the university, but I'll have to sign off about 10 o'clock.
Well, we'll try and get to Dr. Bilder really quickly, I promise, so you can hear what she has to say. Okay, so thank you, Sarah, so much. And I think it's more comfortable for all of us just to be on a first name basis in this group. There are some formalities, but that's probably pushing it a bit. We've all been around for a while, so we can be on a first name basis. And so furthermore, to those on the call, we welcome any visitors to our virtual meeting at this time. The public is always willing to join. And Dr. Zender, fantastic. Good to see you, Brian. If you're logged into the meeting with a phone number and not a name, please type your name in as a comment or state your name now so we can add your name to the meeting minutes. I don't see any of those, but if there are, please let Reshma know who you are. And if you're participating as a visitor and not as a board member or department staff and wish to make a comment during the meeting, please select the raise your hand function appearing at the bottom right of the screen, and we'll do our best, and I will certainly do my best, or Reshma will remind me to accommodate your request to make a comment at the time and you raise your hand. If it's pertinent to the issue, we don't want to lose that comment. But if we're moving ahead and don't have a chance to stop, don't get to you timely, the final item at the end of the agenda, that it was always Dr. Babbitt's most important job was to remind me, and Sarah, if you would help me, and Rich and anybody else, that to open this up to the public. We are fully transparent and want those comments as time allows. And when you make comments, just please identify yourself before speaking and raise your hand using that little function. And also as a courtesy, I think everybody looks like they're very Zoom savvy now. So just keep yourselves on mute just because there are a lot of outside noises. And board motions and votes will be recorded in the minutes. And now on with the agenda. So we do need to approve. Yes.
There's one number that may not be identified, and if they're just on the phone, they will not see the chat request to identify themselves. So just for process 7518, if you could unmute and introduce yourself, please.
I believe that's Katie Carlson. She wrote it in the chat.
Nope, that is not me. I'm here
Oh.
on Zoom. I was asking that person to identify themselves, but
Oh, I see.
we forgot about the phone and chat thing.
Looks like it's a 916 area code wherever that is from.
That's Sacramento.
It's a little more complicated when it's virtual.
Okay, well, it's an honor system, so
Yeah.
that's all we can do is try and honor the honor. All right, so we need to move on to the agenda to approving the minutes. So motion to approve.
So made. Motion to approve.
Second.
Second,
All right. I will assume and all are in favor unless I hear otherwise. Sort of using Zoom approaches to getting things like this done. All right, so be it approved. I've learned a lot from watching proceedings of the Senate on TV for various things, which we're all familiar with, and I'm learning from the president pro tem that you just basically mumble quick and drop the gavel and move on. So I guess that's legitimate, but I'll try and articulate and give everybody a chance to respond. We're going to go through you know what I think we'll do, Rich, let us get to Dr. Builder first, and then we'll do the legislative update, okay?
Yeah.
Because time is of the essence here.
That's a good idea.
So Dr. Red gave us just a really marvelous overview of the autism spectrum disorder as it sort of overlaps with cannabis related things, and then sort of stopped himself in his own tracks at the end and said, you know, with all humility, that, you know, this is not an area of expertise. He's just familiar from his practice and would welcome some additional expertise. And Dr. Deborah Builder has so kindly agreed to provide that additional level of expertise so that we as a board can go forward with some recommendations based on evidence, following the science, as we're committed to do in making some recommendations and sort of conclusory statements and summaries about the relationship of cannabinoids and autism spectrum disorder. So with that introduction, Dr. Builder, maybe a quick introduction to your background, and then I know you've prepared a formal presentation, so I'm just chomping at the bit to hear it.
Thanks, Perry, since we're all doing our first names here. My background, so just so you know, I am not here to represent the University of Utah. I spoke with our legal counsel, letting them know that I would be doing this, you know, just having learned over the years, always let them know what you're up to. And they just said, that is fine. You can talk with the board, just make sure everyone understands you're not here to represent our institution. And so I had to find a new slide background, but I did, and that's what you're going to be looking at just for this presentation. I am an autism expert. I'm an associate professor in the Department of Psychiatry in the Division of Child and Adolescent Psychiatry. I also hold adjunct appointments in pediatrics and educational psychology. I'm a board certified pediatrician, child psychiatrist, and general psychiatrist. My work is nationally recognized in regards to my investigation of prenatal risk factors for autism, as well as adult outcomes related to autism. And my clinical practice over the last 18 years has been with individuals with autism and other severe developmental disabilities. The most common concern that presents to me and this I think has to do with the high acuity settings in which I work, is agitation. Usually it's agitation in the context of someone with a very severe developmental disability. So with that, I can go ahead and jump into the talk. Should I just share my screen then? Okay, okay. Can you guys see that, the cannabis?
We
Use
can
my
see
screen?
it. Looks
Okay,
great.
great. So these are just my disclosures. None of them specifically have to do with autism, except for the very last. As of August, I started a company called Rezero. And I won't be bringing up anything specific to that company here, but I do feel it's important for you guys to be aware of that. So as far as like, I kind of wondered, well, how did I get invited? In Utah, of course, it's legal to prescribe marijuana specifically to treat autism. But I can tell you this was not the recommendation by the Utah Medical Association. And I assumed that discrepancy might have something to do with this invitation. And so I thought I would explain why there was that difference. So a little bit about autism. It sounds like you heard some about this earlier, but it is an impairment in social communication and interaction. Fundamentally, it involves social interaction. Also, individuals with autism will have restricted repetitive behaviors, restricted interests, and what's not up here is that it often can be accompanied by abnormalities in sensory response, whether sensory seeking, wanting, to be held tightly, or pressure, or sensory avoidance, like sensitivity to loud noises or to light. Clearly, many of these children have abnormal responses to sensory input. The onset of symptoms occurs during early childhood. Almost always, it's within the first 3 years of life, although the most recent DSM took away that requirement and just simply said onset within really during childhood, early childhood. And according to the CDC, this affects about 2% of the population. That's not just in the pediatric population. They have done studies in adults, like in the UK, that also found about 2% of the individuals were affected by autism. I just want to highlight here, because this will be coming up. Agitation is not a core feature of autism, although definitely seen frequently among individuals who have autism. It's not a core feature. As far as evidence-based treatment for autism, it's clearly skill-based intervention. And definitely the earlier you get started on intervening with skills, the better, which is why there's such a huge emphasis on identifying autism as early as possible, and why this is part of standard practice and settings where young children are cared for in primary care is active monitoring for all children and screening. The applied behavioral analysis there are other, various therapies. This has the strongest evidence basis, so it's what's typically recommended. But there are other therapies out there. And then there are also specific therapies that really focus on that communication. How do we help these folks who have limited capacity to express their needs and wants to those around them in a means in which people who may not even know them well can understand what they're trying to say. As far as the evidence-based medication treatment for autism, this slide remains blank right now. There have definitely been a lot of medicines out there which have shown signals, which have generated a lot of excitement. But when it really came down to it, which is to meet the standard of evidence required by the Food and Drug Administration, which is a large, placebo-controlled, double-blinded clinical trial, phase 3, nothing has made it through a phase 3 clinical trial. And I'm on a steering committee for a phase 3 clinical trial for a drug that it doesn't take care of autism. And I can tell you, it's a very rigorous process. This process, by design, eliminates random signals or the effects of someone who's really hoping that it will get better. It doesn't take that away. It just allows that circumstance to be compared to someone who has that feeling and is on medication. So there's nothing out there. Lots have made it to phase 3. None has made it through phase 3. Agitation, on the other hand, there is evidence-based to treat agitation. And here's my reminder. This is not a core feature of autism, but boy, if you're looking for agitated individuals, those with severe developmental disabilities are a group that you will find a high degree of agitation often, and they would subsequently be a group that will demonstrate response to antipsychotic medication by reducing that agitation. There's nothing special about having autism or intellectual disability in that regard. They have approved 2 antipsychotic medications for the short-term treatment of agitation and irritability. This often goes on for a very long time, even though that wasn't the approval. It's really the knee-jerk reaction nowadays among medical providers who have patients with autism and are agitated. It's maybe fast and easy, but there's lots of long-term side effects. And the problem is it often actually doesn't fix the problem. The problem is that that agitation comes from something. And I bring this up specifically because I'm going to assume that when people use marijuana to treat autism, what they're trying to do is treat the mood disturbance and the agitation that's accompanying autism. And just like, and for those individuals, that agitation has a cause. It's not part of the autism. It's, and it has a nice differential diagnosis that I've listed here. And when you're treating the agitation, which is the final common pathway, like a clotting cascade, it's the final common pathway. Rather than target the agitation, it's really important to identify, well, what's causing the agitation and treat that and make that better. Problem is, well, and so by the way, psychiatric disorders are very common. It's not unusual a psychiatric disorder is causing this agitation or at least contributing. Over 70% in this pediatric population that was done, the study was done here in Utah as well as in Boston, had an additional psychiatric diagnosis. And you can really see how anxiety, is pretty high up there. We did another study that was a follow-up study here in Utah. These are adults who were identified in the mid-80s with autism. And you can see, just to orient you here, this is the tool that we use to diagnose the presence of a psychiatric disorder. If you look at any disorder, you can see a really high lifetime incidence, almost 70%. In yellow is the current incidence, which is still very high. And then once again, predominantly, you're seeing a lot of anxiety going on here. That's likely going on. The blue, by the way, is the parent report. And I think this just reflects how for most of these disorders, the community hadn't recognized that that disorder was there. I want to point out this because this is going to have a big part in where we're going to go with talking about cannabis. And that is that this population is predisposed to psychosis, more so than the general population. It's still definitely not the majority, and it doesn't justify all the antipsychotic use in these folks, but these folks are vulnerable and they are predisposed to developing psychosis. And that's why it's very important to be conscientious about the medications that are used in this population, because they're the ones who are going to be most vulnerable to develop the psychosis. So the reason why we're in this situation is because the underlying cause of agitation are not routinely identified and subsequently not treated. And this is because most providers don't have the expertise to understand how to identify one of these conditions, particularly in individuals who have limited language. And even if they did have that expertise, they probably don't have the time to ask all of those questions. I have been so fortunate in my career to have practiced for most of it in the neurobehavioral home program, where we really did have the time. We really have the time there to go through all the questions to understand what we're treating so that we can really treat that. And I always realized that I was in a utopia in that regard, and that's something I could never take for granted. But this is why parents have looked elsewhere for answers. Because when they do go to their doctors and the medical providers for help with this agitation, they'll likely get an antipsychotic, and it's very likely it's not going to work, or if it does work, there's all sorts of side effects. So that's why I think in Utah is part of the reason why really marijuana can be legally prescribed with autism, because for many folks who have autism and a lot of other issues, they really haven't been able to respond to the typical practice of medicine. Yet, this is still not the recommendation for the Utah Medical Association. And the reason why is because marijuana has two components in it. There's the THC, which is the psychoactive component. Oh, and by the way, as you were talking earlier about different expertise, marijuana is not my expertise, autism is. I certainly have worked with folks who've had, I can tell many stories, but I do want to say that as I just talked briefly about marijuana, that itself, there may be some errors. This is not what I publish on. So the marijuana has two components. One is THC, which is the psychoactive component, and the other are cannabidiol. And I think that's how you pronounce it, but I have trouble with pronouncing words to begin with, so I'm very happy they call it CBD, and that's what I'm going to keep on using. CBD is FDA approved, and I think, as I had talked briefly earlier, that's a high bar, and it's a high bar on purpose, and that's the standard that's been set in our country for prescribed medications. And it has been approved for seizure disorders, very severe seizure disorders, rare seizure disorders that are absolutely devastating, and it has been able to demonstrate efficacy there, which is wonderful. CBD reduces neuronal excitation, so that probably has something to do with why they've seen it work so nicely for seizures, and that is Epidiolex is the medication that has been approved for Lennox-Gastaut, Dravet, I think tuberous sclerosis. I mean, really, really specific single gene disorders that are absolutely devastating. There is a potential benefit that's currently being investigated for addiction, for anxiety, for psychosis, for autism. So it's being looked at. And what I did see out there, there's not a lot, but what I did see out there for CBD, and I'm not talking about CBD with THC, I'm talking about specifically CBD without THC, is that it looks like the anxiolytical effects may have a U-shaped curve. Like many of the medicines we prescribe, there's a therapeutic window. So I think the more people use this in our community, CBD specifically, the more, now that it's approved to treat seizures, we're just going to understand it better and potentially understand better how it can help people, particularly those who've been treatment refractory with various different conditions. So it's got potential. It certainly has not crossed any phase 3 clinical, but it's got potential. And I'm really curious to see how things work out with CBD over the years, next years. So CBD without THC may have a therapeutic value for psychiatric disorders with relatively minimal side effects. I mean, they're there, but I'm curious to see how that goes over the next few years. Although its efficacy hasn't been proven, if you think about the cost benefit, I have no objection whatsoever, especially when, it's not like I can cure autism. And especially when a family has really, tried treatments to treat not, even the anxiety or the depression or the Tourette or the tics, and nothing's been effective. I don't see a downside if they can afford it to doing a trial with CBD. And we just need to do one thing at a time, and we'll give it a shot. I just want to always make sure it doesn't have THC in it, because any little twitch, whatever THC is going to cause a problem, can cause a problem. We're going to talk about that right now. So THC, the main psychoactive component, it causes the high, it's neurologically activating. It's responsible for these great effects of marijuana, like the analgesia effect, reducing the nausea, stimulating appetite, for folks who just need nutrition and are having a hard time making sure they get enough nutrition. But the problem is it's also the part that's responsible for perceptual alterations, for paranoia and psychosis, impaired learning, memory, and attention. My issue, I have to say, I want to zero in right here. This is my concern. This has always been my concern with folks with autism using THC, is the fact that they are a very vulnerable population, and they are they are at risk for developing psychosis. And I worry about exposing them to a drug which is known to have that potential in a vulnerable person. Well, and I really feel like, there's a lot of hypotheses out there in medicine, is this true? Is this not true? Well, just like vaccines don't cause autism, the door's shut on this one. THC increases vulnerability to psychosis. Like, it just does. I mean, it's well established. It doesn't mean it does it in everyone. But there's no doubt, if you look at the literature, if you look at some, very high profile journals, there are those, it clearly increases risk to develop psychosis. There's increased likelihood of developing psychosis among daily users, and it happens to increase with THC potency. Whenever you see that dose response curve, that's always something to think about. Daily marijuana use and high potency are the strongest independent predictors. I had to include this quote. I usually don't include quotes in my talks. This one was a good one. Independently, and this is in Lancet Psychiatry, independently predictors of whether an individual will have a psychotic episode. It's associated with failure of antipsychotic treatment and in relapse of psychosis. And then those with patients with schizophrenia who have a history of use, they have a longer duration in the hospital to stabilize, and they're more frequently by a lot. I mean, talk about effect size on that one, higher rate of readmission. So I'm not implying that everyone who smokes marijuana is going to become psychotic. What I'm saying is that this potential side effect makes me very concerned about this population. So let's talk about autism and psychosis. Just a bit more. Individuals with autism, as I mentioned, are at higher risk for developing psychosis. The propensity towards psychosis and autism is clearly unmasked by FDA-approved drugs. I mean, drugs that have clearly proven their efficacy in what they're supposed to do and their safety, in the general population. And these include stimulants, atomoxetine, which is also referred to as Strattera, amantadine. It's like, but they do know. I mean, when they did these trials, they did realize that there was an increased potential for psychosis. It's just, relatively minimal. And unfortunately, folks with autism are just, when I see these folks on these medicines, it's usually a problem. And it can present with psychosis. The issue as well is that it can take months, sometimes years, to see this complication emerge. It's not something I expect to see right away. In fact, when you do see it right away, clearly the family puts that together and like, whoa, this is scary. We're not going to do this. And they'll tell me about it later because I'm not the one who started them on it. But more often than not, in my experience, it takes months, if not years. I don't know what exactly is is changing in the neurochemistry of the brain, but something's changing in the neurochemistry of the brain that then pulls this out. A core feature of autism is the inability, little typo there, to communicate one's thoughts and feelings as effectively as others. This is a problem when you have psychosis because you want to monitor your patients really closely for this potential side effect. Because, as soon as you see it, as a doctor, you'll just stop it. Like, whoa, we're done. And maybe things will be fine. I mean, it's not always fine, but it could be. And there was a reason why you recommended it to begin with, theoretically. And, certainly the other medicines that have FDA approval. But when someone is unable to communicate readily their thoughts and feelings, it is likely that they will be experiencing psychosis a lot longer than you would want them to before you're aware that this was going on. The other thing too is because psychosis is something that emerges over time, patients and their families do not attribute the agitation that's caused by psychosis to the medication that was started months and years ago. I see this over and over and over again. Like, this is what I do for a living. I wish I should look at the proportion of consults I do with an individual with very severe disabilities, often autism. There's nothing like autism to just make it all that much worse. Come into the hospital, or I get pulled into a situation, and part of why they had been so treatment resistant is because they were on an FDA approved drug that caused this agitation as a result of mania or psychosis. Happens all the time. And it was never put together because it didn't happen right away. It emerges over months, potentially years. but where's the evidence for supporting autism? Because, these other drugs are FDA approved to treat something. And in medicine, particularly in child psychiatry, it's not unusual to use something off-label. I'm certainly not pure in that regard. There's just not enough studies out there to always insist you're always on label. But at least what I prescribe is FDA approved, and we know exactly what it can do and what it can't do. So you've got that awareness. So in the support of THC for autism, there's lots of testimonials. There's a few published case reports. I found one, but I'm sure there's some others out there. There's one retrospective study that demonstrated a reduction in agitation in 44 out of 60 children after it was retrospective, and they'd been taking it for, I think, like at least 6 months, maybe up to 2 years. I think they looked at a registry that they had, like in Israel or something, once people were able to start getting this medically. The problem is that one of the girls actually developed psychosis after 6 months. I mean, like, I'm not surprised. Thankfully, it was discontinued and it went away, which is fabulous. It does not always go away. And my hope is that they found it early. I suspect if she'd only been on it for 6 months, it probably was pretty early that they found it. And then 2 other children had an escalation in their agitation, early on. However, this was enough to pursue a double-blind placebo-controlled trial. And I would agree. I would see this as enough to go for a phase 3. I think that makes sense. The problem is that this trial, into the credit of those authors, it was published. This trial showed that it failed to meet its primary endpoint on efficacy. It only put them on for about 3 months. And so from the perspective of side effects, it never really had the opportunity to see these longer term side effects that we'll see. But it did fail its primary endpoint. Now, against using THC for autism, psychosis is a real problem. And I mean, I feel the door is shut on the fact that THC can predispose to psychosis. And I can personally share several stories of patients with new onset of psychosis, sadly, after being on THC for several months. What's sad for me, I think there's one, for those doctors there, nurse practitioners, physician's assistants, maybe nurses, certainly as well, that in practice, even after many years, there's a situation that can just touch you. And you just always have that thought and that patient in your mind, and they're ingrained in your head. And there was one such young man about a year and a half ago who had followed for many years. And we really had the hardest time getting on top of his agitation and anxiety. And his mother wanted to try marijuana. She let me know she was going to do this. I let her know that I don't think it's a good idea, but you can stay my patient. I'm not going to tell you what to do. I can't cure this. So, but thank you so much for telling me. So she went to California, and he was, prescribed marijuana. And for the first few months, he'd come in, I'm like, wow, he's just, he's talking better and he seems less anxious. I'm thinking maybe I need to revisit this. I can see how this is better. And then I don't hear anything for 3 months, and you kind of just assume things are fine when someone's doing well and you don't hear anything for 3 months. And then he presents with this florid psychosis, florid. And it took us he was hospitalized at uni with a 2 to 1. It took us 3 months to stabilize him, at least 3 months to stabilize him. Of course, we stopped the THC right away. We were able to stabilize him. I don't know if his psychosis ever resolved, but at least we were able to stabilize him. I understand about a year later, this parent wants to try THC again, because maybe a different strain, maybe a different strain might work. And I just am like, you've got to be kidding. That was the worst. floor psychosis I have seen in someone autistic ever. I've been doing this for 17 years. But for her, she remembers the good times. She remembers those first few months, when it was better. It was so much better. And the bad part, which was absolutely horrible, she just still couldn't attribute to the THC, even though it was like, that's what it was. And so that just, and I just remember being surprised by that. And then that just helped me understand, for parents who are so desperate, for something, it's hard. It's not something, I think she'd hoped a different strain will do it. And, it's like if there's THC in it, there's THC in it. I mean, it's like a stimulant, like there's all sorts of stimulants. There's all different preparations of stimulants, because, but you know what, stimulants cause psychosis. So the standard of proof, despite the promising testimonies, there's no evidence meeting the standard of proof in medicine to support THC's efficacy in treating autism, like not even close. Yet there are mountains of strong evidence demonstrating that individuals with autism experience a greater vulnerability to developing psychosis. Like that's not, like that door's shut too. And people accept this. And then THC causes psychosis in vulnerable individuals. And I'm not sure, where you all are coming from, but the evidence that I see out there makes me pretty comfortable saying that's true. So those who treat autism with THC, so in other words, those who target autism itself, like that's going to be their treatment for autism, do so at their peril, because it's not going to, like, I'm waiting for the study, it's not out there. And the problem is because of the psychosis, like if it was just like B12, or, fine, give it a shot. But the problem is there's risk, there's danger. Those who use THC to treat agitation associated with autism, for which we do have a couple antipsychotics that are FDA approved, can really be creating a much bigger problem. And I've just seen how it's hard for folks to put those two together, even with it just right there. So CBD without THC may have a therapeutic value because of its side effect profile, which exists, but it's not psychosis. I see no problem whatsoever with doing that. And there, there's no strong evidence for efficacy, but that, let's try some, decent trials, and, so we can understand better what it can be helpful with. Although there evidence for efficacy in CBD in psychiatric disorders has not met that standard of proof, if it's CBD without THC, I mean, like some folks are like, well, what about this strain? It's like, if there's THC in that strain, it doesn't matter. That's the problem. I mean, like even like these like 120 or whatever, like if there's THC in there, if that individual has autism, you can see the effect, do it without the THC. It's a reasonable option if proven therapies have failed and cost isn't prohibitory. So, so that's my talk on, and just to remind people of my disclosure, I am not here to represent the University of Utah. Rather, this is just to give you just what my understanding is in regards to autism and why I worry. Why the UMA, who called me before they told you, the legislature, this is not a good idea for autism. Where that came from is here. And I'm sure I'm one of many, but that's why I just did not think it would be a good idea for the UMA to endorse the use of THC for autism.
Debbie, thanks a million for going through with the literature, for sharing your practice experience and your perspective. I'm going to give first at bat to Dr. Red. Ed, who's been through the literature to a certain extent, and any questions for Dr. Builder, Ed, that you came up with? I hope you were taking good notes, because I'm going to charge you with the responsibility of putting into the template that we've established those recommendations and incorporating Dr. Builder. And what we've sort of done, Debbie, just as sort of a matter of process, is when we've had outside experts, we'll share our recommendations with that expert, just to sort of see if there's anything you want to add or your thoughts, any edits. Obviously the board has the final vote, but we But we certainly want to give you the opportunity when we, in the next few weeks, when we develop some conclusory or summary comments for this particular area, to give you an opportunity to look at it. So that, if you're so willing, so that's how it will go. So Ed,
Sure.
have at it.
Sure, thank you very much. Really enjoyed the presentation, and really was very helpful to have somebody with expertise in autism talk, because most people, I think that, I can't speak for everybody, but not every child with autism or adult with autism has access to people with this level of expertise in treating autism. I think that's important first to understand. And so I think as a board, it's important that we make recommendations or suggestions or guidance, provide guidance for using autism for approved conditions under the Utah code. It's important for everybody to understand the limitations of what we understand and the potential harms that can happen. At the end of the day, a lot of people will probably be, not a lot of people, but some people will probably use this intervention. I think the data that I looked at from Israel, which there's 3 studies out of Israel that were more observational nature than this last one that you referred to as a prospective trial that was randomized, not blinded, but randomized. Well, I don't know, maybe it was blinded, but bottom line is it was randomized trial. And that study did show a reduction in behavioral problems. It didn't have any effect on the core effects of the intervention. It didn't have effects on the core problems with autism, but the comorbid conditions of the agitation and the combative behaviors and things like that. It did show reduction. And again, it was a very short study relative to the long-term potential complications that were talked about in Deborah's presentation. And I think it's important as we go forward that we basically make sure that people understand the extreme limitations of what we understand, especially about the long-term potential problems that might happen. But my thoughts are is that the randomized trial that came out of Israel just recently was referred to did show some reductions in the comorbid agitation problems. It certainly didn't have any effect on the core symptoms of autism, that were mentioned, such as the repetitive behaviors and the impaired social interactions, but they did show some reduction in the CGI. I think that's what they call the CGI scores of these patients. And again, this is placebo controlled, and the improvement was present was noted in patients who did get the cannabis product and didn't get the placebo. I think the thing that's really important though is what she mentioned about the whole psychosis thing. And what I don't know, the one child in the one study that did develop psychosis was doing a 10-to-1 ratio of CBD to THC. And the rest of the kids were doing 20-to-1. And most of the studies out of Israel all use 20-to-1 ratios. And I've often asked myself, well, why is that? And again, like we talked about before, I think that's probably because their observations in the past have shown that using higher THC content cannabis is not necessarily a great idea. And I think that Deborah's experience in this area is extremely important, and I think we need to include her observations and the summary of this in our final thing. I can tell you I can tell you though, the parents who are looking into this. And the providers, the healthcare providers that might be recommending it, do need to understand the risks and or the potential risks. And I think that's also extremely important. The difficulty with dealing with autism, I think Deborah mentioned this as well, as far as these people have a really difficult time explaining what they're experiencing. And I've seen this in adults with autism who you're talking to them on your Zoom telehealth medicine thing, and they're having what you would consider a normal two-way conversation, but they're actually experiencing suicidal ideation. They can't express that to you. So I think the concept that we're not gonna be able to pick up on this, we're gonna have troubles, whenever we're doing this as providers, people need to understand it. it's going to be tough to pick up on the fact that they're not doing well until they're really not doing well, until they're really going down in flames, kind of not doing well. So I think it's important to understand that. My thoughts are is this is a great presentation, and I'm really grateful that Deborah took the time to come and give it to us. And I just think, as we go forward, we need to certainly include the concerns and the lack of information we have about this intervention and potential risks that are involved. And that's basically what I'm going to say.
Well, thanks, Ed. I want to sort of summarize some of the comments that I'm seeing on the chat side. There are a lot of phase 1, phase 2 studies that I'm aware of in a lot of areas now with different cannabinoids, and certainly some studies with autism where some cannabinoids in combination are being studied that may be promising. Obviously, a lot depends on methodology, on patient selection, on patient exclusions, all that kind of stuff where the devil's really in the details before you can generalize. But I'm very glad to see, and I think all of us are happy to see in a lot of areas, these studies are now finally going forward. I've always said we're a quarter century, maybe even a half a century late in our science because of the prohibitions that have prevented good studies. But what I've learned from your presentation, Debbie, is that not unlike looking at pain and opioids, where everybody seems to do well for a little while, but it's really what happens in the long run with ongoing long-term exposure to this class of drugs, whether it's opioids, whether it's cannabinoids or cannabis, whole cannabis in various forms. We don't really know until about effectiveness for the long run. We can make comments about short-term efficacy, about short-term risk, but in terms of effectiveness, which is really that, over the long-term use and exposure, what happens to individuals and what's the true incidence of benefits and burdens. So we've got a lot to learn. You've been extremely helpful. The problem with and the limitation of and maybe Rich, you can say maybe a bit about this. I certainly see one of the limitations of not only our program in Utah, but around the country is we're really not talking about specific cannabinoids. We're talking about strains of cannabis, marijuana, that we're measuring a couple of cannabinoids, CBD and THC. And then those have, metabolic byproducts is like THC, and they've gotten CBD is metabolized depending on the dose to active and inactive forms. So there's all these confounds that really prevent generalization and to determine if somebody tries something, will they get the same thing next time and next time and next time. And I think we're a little better in Utah maybe because we've required this grammametric analysis of CBD and THC for the strains. But even that has yet to be fully, as I understand it, systematized within our program, but we're getting there. Rich, you want to comment about that a bit, just from the product standpoint?
Yeah, our program with help from the Department of Agriculture and Food, they require independent testing laboratories perform testing on the products as they go through. And that way providers and patients and parents of patients can educate themselves about what is actually in the product and to what degree, right? Some other states don't require that. And some states require testing, but a lot of times it's not an independent lab that does the testing. So I think we've started our program in a smart way in that respect. And I think over time, we'll find that there will be additional testing laboratories in Utah. Right now, my understanding, there's only one. And then also the Department of Agriculture and Food does some testing. In the future, there'll be more. That's important as well, just to give these cultivators and processors more options to where they can go for testing. And that, I think, has during the early part of the program, there's been in some periods a bottleneck because of the need to test, but there's definitely value in the testing. And there's value in a provider and a patient or a parent going and investigating what that certificate of analysis shows about the particular product, right? There's a lot of value in that, but it's a challenge because of the fact that there's not a lot of studies on some of the, we see studies on the CBD and THC, not as many as we want, but then there's so many other cannabinoids, right, that we would want studies on, and some of those, of course, are mentioned in the chat, but we just don't have them yet, and so it's something that is yet to be done, that needs to be done.
So one thought I have just in listening to Ed and you, Perry, and Richard, the thing is the train has left the station. It's approved and it's legal. And so one suggestion, and the other thing too is I didn't say that it would be inappropriate to use marijuana in someone with autism. It's that I don't think it should be attempted. I don't think it would be under the guise of treating the autism. And also I'll go as far as to say, and treating the agitation. So for example, I've had another patient who's very high functioning, quite articulate, who has chronic pain due to his underlying genetic disorder. And thank goodness for marijuana, because for the years I worked with him, I didn't have to worry about him dying from an overdose of opioids because he was on opioids, because the marijuana helped contain the degree to which he would seek opioids in addition to what he was getting prescribed. And he did a great job articulating what he was experiencing. And so if he were to experience psychosis, he would let me know that. We monitored that whenever I would see him. And I, so like, I think like it's not that someone with autism should not have an opportunity to use marijuana for something like chronic pain. It's that my recommendation is that just like the stimulants, if you have a history of psychosis, like that's, that might be a contraindication, for being on a stimulant. And that could be a very appropriate, that should be a contraindication for being on, for being on marijuana to treat autism or agitation is a history of psychosis. The other one too, just for me, I do not prescribe trazodone in my male patients who do not have the language to tell their caregiver that they're experiencing priapism. I just don't feel comfortable with that because, it's uncommon, but it happens. And so I don't. But I certainly use trazodone. And I informed them, just as Dr. Rett was saying, and I absolutely inform, the male patients and their caregivers that this can be going on. And we have a discussion, and we decide, can they tell you? How would they tell you? Okay, now remember, you need to tell your parents, and then we're good. And then if it happens, they know what to do. We've got an emergency plan, and so I can use it. So I think, so it's not, I guess what I'm glad you guys are giving me this opportunity to make clear that it's not that there's this absolute contraindication for mixing autism and THC. It has to do with specifically using it to treat autism or agitation in autism. And it also I think it's important that the individual have demonstrated the capacity to report psychosis if they're having it so they can stop it right away. And that they haven't previously experienced psychosis because they would obviously be a really high risk. So.
Thanks, Evie. Really good points. And, the more we talk about this, the more I can see parallels between, these issues about non-self-reporting individuals who can't really express what they're thinking, feeling, experiencing, whether it's pre-verbal children, children with living with autism, older individuals with dementia. I mean, a lot of those patients who I see in the same challenges with treating pain and mood disorder associated with dementia, is it dementia? Is it something else going on? And it's always a challenge to unwind this. But, we're still stuck in that age-old conundrum of, studies evaluate populations. We treat individuals, and we have to try and somehow put those two together and make sense on behalf of all the best interests of that individual. And so, Debbie, from a standpoint of sort of where we've taken on in this board is to help do our very best to inform qualified providers, and I guess there will be some limited providers, the individuals who can recommend under the program use of cannabinoid products, as well as the public through our website that goes into detail about these different conditions. In this case, it'll be autism, but we've gone through several others to flesh out what we know, what we don't know, what we wish we knew, but what we can conclude based upon best evidence at the current time, and maybe aspirationally what needs to be learned in the future with regards to the potential therapeutic value of various cannabinoids or whole plant extracts, etc. Your presentation has really helped add to that, and Ed's going to meet the challenge of sort of summarizing these issues with regards to autism, and then we'll pass those to you so you can review them as our sort of outside expert, if you will. And then we'll be posting what the board votes on and concludes on the website, and that will be then available for all to see. And hopefully on an every other few years basis, as we build more of an evidence base in various conditions, our program and our website will be what we aspire to be, which is a leading edge, both within the state but nationally, of evidence-based practice with regards to cannabis and cannabinoid products for the treatment of a host of conditions. So thank you for contributing. I just want to make sure that we do have a bit of time. If anybody wants to raise their hand and ask Dr. Bilder a question before she signs off. Deborah, if you've got a few minutes, we'll see if anybody has any.
Sure.
I do. Have I got a question? Can you hear me?
Board or outside board.
Oh, Dr. Sudwell.
Hi, Doc.
Hi. I'm sorry, I came in late and I missed Rich's legislative update I wanted to hear. But anyway, I'm a QMP and I also have this fancy title of presiding officer of the Utah Medical Compassionate Advisory Board, which has been a really funny title because I haven't had to do a darn thing. I'm supposed to adjudicate if there's a difference of opinion on an approval, but the Compassionate Review Board's done such a great job, they haven't had any contention, I guess. But my question, I want to see if, Deborah, I was really interested when you had this patient who was, I guess, seriously mentally ill and would tell you when they're hallucinating, because I had an unpleasant circumstance kind of being called out as a QMP. I never talked to the parents directly, but I approved a young man, 28 years old, homeless, who was presented well, was articulate, seemed intelligent and functioning fine, even though we don't know where he lived. But anyway, he was apparently schizophrenic and his parents were angry that we'd approved his use of marijuana or these cannabinoids or the medical drugs. And I had no idea from his presentation. I was impressed that you said your patient could tell you about his hallucinations, but this man was not forthcoming at all. And as I said, was articulate. And can we have a blanket statement saying that if you're schizophrenic or having hallucinations, we should not use cannabinoids? Should that be part of the board's recommendations? I'm not clear on that.
Are you asking me?
Yeah.
Yes, I think that a contraindication
Okay.
for using cannabinoids is someone who has a history of psychosis and a history of schizophrenia. So the individual I talked to you about, I felt comfortable with him telling me that he was psychotic. He didn't report psychosis. So Dr. Sudwell, you're not alone. He didn't tell me he was psychotic. But I felt comfortable that when I watched his functioning and so I would end up, we'd have like an hour each, once every 2 months. He was on a pretty high opioid regimen by his primary care doctor. And so we just kind of kept a close eye on him to make sure that it was okay. He was doing okay. And I never was concerned that he developed psychosis. And I also felt that if he did develop psychosis, he would tell me. But what you just described reminded me of, I might be, maybe I just kid myself. I mean, as a doctor, it's so often you think you'd be able to figure something out, and yet you're later caught off guard that, yeah, you didn't catch that one,
Well,
so.
Yeah, this guy presented himself so well, and I had
Yeah.
I didn't have a history of his mental illness until his parents spoke up. And Rich, I don't know if you heard any more from that family, but I never did. I never heard anything back, but it was brought to my attention that they were unhappy that we'd approved him for the cannabinoid.
I just wanted to say one thing, that in regards to kind of making psychosis a contraindication. I'm trying to look back and see what language we use, but that's listed as an adverse outcome and a population to avoid. I like the suggestion of changing the language to contraindications in FDA medicines. That's a usually respected warning, whereas others are not. But I mean, I don't know if that will translate to providers not using it when there's a history of psychosis, not to mention the problems that you're mentioning. Patients are not always going to be able to relay that or willing to relay that. But I just wanted to say that is, if you look in the package insert, if so to speak, that's listed as a population to avoid and an adverse outcome.
Well, one thought about this topic that, if I could, I just like to add is that one of the core duties of the Cannabinoid Product Board is to put together guidance on suggested use of medical cannabis, right? And you've done such a thorough job of creating guidance for the specific conditions under Utah law are authorized to be treated with medical cannabis. And I just brought up the autism one, and I think one option is the board could evaluate how that specific suggested use of medical cannabis document can be amended based upon information they collect from researchers like the one we heard from today, right? So that fits within, I think, the definite scope of the Cannabinoid Product Board. And it is what it says it is. It's suggested use of medical cannabis. It's guidance, right? There is not a change in the law that says outright you cannot use this product if you have a psychosis or whatever. The law doesn't say that. But what the law allows is for the Cannabinoid Product Board to incorporate in their guidance a contraindication based on evidence in scientific journals and information that's been collected. And that would be up to the board as to how they would want that guidance amended, because there's current guidance out there that you've done such a good job of creating with help from Dr. Red and others. So that might be a good direction for the board to go, just amending that existing document to maybe make some more specific recommendations related to psychosis.
With that
Thanks,
particularly
Richard.
vulnerable population.
Let's see, Dr. Woolsey's been waiting in line, I think first in line for a while. Sarah, you still with us?
Yeah. Just appreciate Rich's summary of the discussion of psychosis. And then the other thing that I want to just highlight in the presentation is, being clear, we're not treating autism, we're treating, expressions of autism. And that in some ways may be another aspect of refined language to consider. Just want to bring that up. That's not the topic for today. It is psychosis. And just appreciate in my quick onboarding in the last couple of weeks with QMPs that I have reviewed their recommendations for patients in some cases, they are talking about psychosis. And we need to continue to make sure that's a strong point of education for QMP. So I really appreciate this presentation, and we're going to make sure that lots of folks have access to it. So those are my 2 comments. Thank you, Dr. Fine.
Thank you, Sarah. Blake Smith, I think you were up. Do you have a question for Dr. Builder?
Yes, please. Can you hear me?
Yes, I can. Hi, Blake.
Oh, perfect. Hey, how are you doing?
Good. How are you?
Good. Thanks for the presentation, and thanks everybody on the board for all the good work that you do. I hope my comments are never taken to be felt personally or anything else. I just spent a lot of time doing this and researching. My specific question, we talk a lot around psychosis. In all the research and everything that I've read, there is a strong implication or indication around drug-drug interactions. But I'm mostly curious about what specific neurotransmitters are associated with the psychosis we're talking about, and either the expression or inhibiting of which specific neurotransmitters. Because in endocannabinoid receptor system 1, which is the synaptic metabolism of cannabinoids, they're mimicking specific neurotransmitters to get a certain effect. And so knowing those would also help indicate which cannabinoids would have more of an effect versus others in terms of either, habitualizing or making worse various forms of psychosis. Does that make sense?
Yeah. So Blake, that's an excellent question. Because so much of what I think we do in medicine is we try to thread the needle. I mean, we want people to get better. So much of what we do could have this side effect or whatever, but if we can kind of figure out, well, if we dose it like this, or we do this, or we use this medicine in the class versus this medicine in the class, we can get past that. And the way that helps us, one of the fundamental things that helps us understand, why would you go with this drug instead of this drug, is by understanding the underlying mechanism of the efficacy, why it works, as well as the underlying mechanism of the side effects. Like, where did this psychosis come from? And it sounds like you've done more reading than I have in this particular regard, but I can tell you what I did read about this. There is so much about cannabis that they really don't know. Like there's definitely part of it they do know, but boy, there is a lot of the way that drug works that they don't, it's acknowledged, when you look at this. And so you were asking,
and I myself will acknowledge that.
Right, exactly. And so,
yeah.
And the other thing too is, if we knew which part of this specifically leads to the vulnerability for psychosis, maybe there would be a drug that you could use with it so that it doesn't have that potential side effect, and yet you can get the benefits on the pain and the nausea and the appetite, stimulation. We just don't know. We don't. And I really, but that's today. And as a result of this being a legalized substance, because there's a lot of people out there who can benefit who are not predisposed to psychosis.
Right.
I think we'll learn a lot. In this particular board, I don't know to what degree you are required or allowed to, keep records of those who are receiving this medicinal medicine. But 4 years from now, 2 years from now, those folks who chose to try this, in hopes that this will be what works for, that untreatable ailment they have, we could understand from those experiences that much better, who is at more risk, who does benefit most. And I really hope that, now that it's legalized from this perspective, I just really hope that we just are able to learn that much more. So 4 years from now, maybe we'll have an answer to that question, Blake.
That's
Deborah,
great.
to answer your question, maybe you heard right before we started the meeting, a couple of minutes before I think you were on speaking to Rich. What we're avidly working towards on the board is developing a more sophisticated database and a meaningful database that will allow us to come to some kind of conclusions with regards to certain intermediary outcomes, but especially with certain end outcomes, as you're implying. And So there are efforts to develop some data sharing propositions with some. I know you probably know Jerry Cochran and that work group at the university, but who have expertise in this area. And so we're working towards that.
That's great.
We could get into a lot of detail now that I think we probably don't want to, but at some point, we'll, and that's, I'm going to talk about this a little at the end of the meeting. But I know you may, if you need to go, I think there's one more, we have time for one more
Sure.
question if you do.
Sure.
Harry,
Jean?
Harry, before we do the question, can I interrupt and correct something? I'm sorry.
Oh,
Real
sure,
quick.
sure. Absolutely.
Schizophrenia spectrum and other psychotic disorders are listed in the several contraindications in guidelines for prescribers. So if you go to medicalcannabis.utah.gov, it's listed clearly as a contraindication. Thanks. Sorry about that.
No, Dr. Carlson, thank you. That's why we have this expertise on the board to help answer this. Jean Sakaki, I think you had a question. Are you still on for Dr. Builder?
Yes, thank you, Perry. And thank you, Dr. Builder. This was a very well put together presentation. Thank you to everyone for the board. I just had a quick question for you, Deborah. This is particular the individuals with autism that are at a predisposition to necessarily have psychosis, not so much cannabis induced psychosis. Is that correct?
That's right. That's right.
Okay.
Yes. And what it's, and I think as Blake pointed out, it's not like we know exactly what's going on. Like we don't, but they've demonstrated their brain's vulnerability to have psychosis from whether it's on its own, whether it's from stimulants. It's demonstrated just kind of where that person's brain is in regards to their vulnerability to experience that effect.
Okay. Okay. Understood. Thank you for clarifying.
Sure.
As we are, self-admittedly learning more about cannabis in general, one thing I do want to share, I shared in the notes, as we currently learn more about the different cannabinoids, there's, precursors to certain cannabinoids as well. And we found that THCA, which is the precursor to THC, so it's THC acetate, tends to be non-psychoactive. So we found in other markets, I'm looking right now, I'm talking with my medical team about finding some studies, but THCA in combination with CBD would still be non-psychoactive, but would still have the therapeutic effects of the THC and the CBD without any of the psychoactive components, which may trigger some of the psychosis or lead to thereof. With that being said, would this be more of a conversation of finding more use cases and more studies where THCA has been mitigating some of the psychosis, but still able to effectively implement some of the medical benefits of said THC?
So I think that's a really good question, and it just goes to how we're just learning that much more about this drug. It sounds like there's a particular component of the THC or a precursor of the THC that looks promising as an opportunity to really kind of have your cake and eat it too. And I think that's fantastic. I think about what Blake and I were just talking about. We really don't know exactly what it is. Like you're right, maybe it is the aspect of it that makes it psychoactive. Like maybe that is what it is. And as a result, I think something like the drug you're talking about may be able to avert that particular side effect and still get the benefits, which would be wonderful. And so I could see how that could be promising and something to pursue. I, as a provider, you get your phase 1-2 going. You've got your NDI filed. Then if you see promise like they did in the Israel retrospective study, then you go for a phase 3. And when you make it, my recommendation, I don't know if you're actually involved with the company that's developing this. I don't know if are you part of the company that's working on this?
No, I'm a part of we're part of a pharmacy at the retail level. So
yeah. Okay. So my suggestion is for whatever pharmacy, or excuse me, for whatever company, which is, trying to design this medicine to be able to thread that needle, that they, think hard about what endpoints they're going to use as a primary endpoint to suggest to the FDA, because and that they do the trial, for at least 6 months, because it really does take a while to see this come out in many of these folks. But I hope that company that's working on this is really thinking through what endpoints should they list. As Dr. Red brought up, they picked the wrong endpoints for that study. But the problem is it may be that the FDA lets you know if they'll accept your endpoint. And so it may be that they proposed another endpoint, but the FDA said that's just not going to cut mustard.
Okay.
And so I really hope that to set up for success, that they're very conscientious of what they put together so that it has that best opportunity to make it through the phase 3 clinical trial finish line.
Okay, thank you so much. Excellent job I know you put a lot of time into this, and you know more about this than probably anybody in the space. So thank you.
Actually, Blake knows more about what's. I mean, I have to say, I bet you have done more reading than any of us in regards to, just community awareness, the physiology, like everything. Like, there's nothing like having an individual who just sees this as something there. No, but thank you for that. Thank you for that comment.
Thanks, Bijan and Deborah. And for those who are going to stay on till the bitter end here, which is 35 minutes now from the bitter end, I'm going to make a bit of a proposal actually that will tie in a lot of these thoughts about where we are with regards to the state of the art, state of the science. So stay tuned for a few minutes if you can. Deborah, if you got to go,
Okay.
whenever you sign off, thanks a million. We are very grateful. You'll be hearing back from us in a little while.
Sure.
So now I want to turn it, David Sunwell, I don't know if are you still on the call? If you
Yeah,
are,
can you hear me?
Hey, David, it's good to see you. You did not miss Rich's summary. We delayed it. Just I must have been prescient that you were going to sign off.
I'm
So,
technologically handicapped and I had trouble patching in, but I finally got it. So I'm glad to hear Rich's update.
Well, great. It's
Let
great to see
me
you.
just say a quick thing, because I'm just going to want to share this with the board. I have this title, as you know, as the presiding officer of the Compassionate Review Board. The intent of that was to adjudicate if there were claims against their decision made by the review board. Fortunately for me, there hasn't been any of that. Unfortunately for me is they haven't allowed me to attend the meetings because the lawyers said I would be biased if I heard the discussions and I couldn't be independent, which I thought was pretty silly. But at the same time, they've done a great job with this. I just tell you, as a QMP, I've been active in this since the full year. I maybe have now reviewed 70 plus patients. And I just want to share with the board, I am a believer. I am so impressed with the testimonials, if you will, of the patients who've been using the card to come back for their 1 month and 6 month follow-ups. I would estimate, without having kept good records, that 90+% are pleased and getting a benefit, using less opioids, getting relief from whatever thing they were approved for. So it's just been astonishing to me. I've been surprised, and I hope the board is aware of this positive evidence. It's again anecdotal, and that's why I love the fact that you were talking about research and this board coming up with some really good data, which I think other states won't have. This is an opportunity for leadership in Utah, but I'm impressed that we're going to see much more therapeutic use of these products in the future.
Thanks, David. We're certainly making an effort, and if anybody deserves to have the nickname Solomon, it's you. so keep at it. Rich, you want to give us the update, and then I want to get to a few minutes of discussion with this so-called proposal, and then we'll hear from the public and move on. You're muted, David.
I'll share this with Reshma so she can post it in the future if you want to access it. This is just a very high-level summary of some of the primary amendments to the Medical Cannabis Act that came during the legislative session. And so one of the primary bills was Senate Bill 192 that was sponsored by Senator Vickers. And some of the most critical parts of this, and I want to emphasize, this is just a high-level summary. There are more amendments than I have time to summarize in that bill. So just keep in mind, this is just the high level. So medical cannabis product and card information is to be sent to and incorporated into Utah's controlled substance database. We'll be working with DOPL on doing that over time. Of course, this requires significant software and technical work to ensure that that is done in the best way. And I would expect that it'll be sometime in the fall of 2021 when this would actually come to fruition. The prohibition against alteration or removal of medical cannabis product labels. So this requires that the original processor label that appears on that product container, that remain on the container while it's being used by the patient. And that would help if upon investigation for some reason there was a need to confirm that that product was purchased from a Utah medical cannabis pharmacy, it would have that original label that has that unique identifying number. So that's one of the reasons why that was put in there. Also, the Utah Department of Health is to issue a 15th license to a medical cannabis pharmacy located in a rural county. So it has to be in either Daggett, Duchesne, Uinta, Sevier, Grand, San Juan, Emery, or Carbon County. And we don't have a timeline on that right now. I know there's some people that are very interested in knowing what that is, but we need to coordinate with the Division of Purchasing because that license will be awarded through the appropriate RFP process with help from the Division of Purchasing. A QMP is another amendment is just that the QMP is not ever required, but they're given the option to submit treatment and medication history to the electronic verification system when they choose to not recommend specific directions of use or dosing guidelines. So the previous law did require that they upload medication history or treatment history. And this just requires it if the QMP believes that it would be helpful for the pharmacist at the pharmacy to be aware of medications A, B, and C that this particular patient is on. So that was an amendment that was made. Also, his bill requires a medical cannabis component be added to required continuing education for controlled substance prescribers. DOPL already administers an existing CE course every 2 years for all controlled substance prescribers, and the existing course will be amended to include a small medical cannabis component. Medical cannabis card holders may legally possess under Utah law medical cannabis product purchased out of state until June 30th, 2021, if it complies with Utah standards for medicinal dosage form and amounts. That was an extension. The previous deadline was January 1, 2021. That deadline has been extended. So people can purchase out of state and under Utah law, at least, legally possess in Utah under certain conditions until June 30th. It also clarifies that a pharmacy medical provider, which up to this point, they're all pharmacists, they at the pharmacy, they must review each medical cannabis transaction before dispensing the medical cannabis to the cardholder in accordance with pharmacy practice standards. That was emphasized as a clarification of intent, and we'll be making some software changes to reflect that intent. Senate Bill 170, that was Senator Escamilla's bill, also sponsored by Representative Ward. This states that podiatrists can qualify as a QMP within their scope of practice as a podiatrist. So they're treating, they're within their scope of podiatry, and I think most of these will typically be like chronic pain, maybe of the foot or toe or whatever. They would then treat that potentially as a QMP if they chose to. They have the ability to apply and be a QMP. So they join MDs, DOs, APRNs, and PAs. Also, physician assistants will not be required to be supervised by a physician who is also a QMP. That was a change that came on primarily under Senate Bill 27, a separate bill. But because that bill passed, this also needed to change, and Senator Escamilla chose to make that change in SB 170. So physician assistants under the new bill do not require supervision of a physician. They're always practicing within their scope and knowledge and expertise. And those, I think, should impose some limitations on what they can do naturally, but okay. And then there's multiple changes required to our software. These changes will likely take some time to implement just because of the fact that the Department of Health, we need to work with our vendor in order to carry out these changes. So one of those is just the increase of the time frame of initial issuance of a medical cannabis card from 90 days to 6 months. Limited medical providers, the current law, or I'm sorry, the previous law does not have this limited medical provider avenue for recommending cannabis, but the new law will, and it'll allow any podiatrist or MD or DO or a PRN or PA to recommend to up to 15 patients without registering with the Department of Health. And they would not have to use the electronic verification system to submit their recommendation. It would operate similar to how a prescription works, where a doctor, so many prescriptions these days are done electronically, as you know, right? And we would recommend and highly suggest that these orders from a limited medical provider be done using electronic process of secure email or something, but there needs to be some communication set up between the limited medical provider and the medical cannabis pharmacy. So the medical cannabis pharmacy can know the name of the medical provider that's recommending or ordering, and the condition of their patient, the name of their patient, the license number of their limited medical provider. The same information that has to appear in a controlled substance prescription is required to appear in this order or recommendation to the patient that would be communicated to the medical cannabis pharmacy. And then at the medical cannabis pharmacy, an employee there will enter that recommendation into the electronic verification system. So there's this high degree of trust between the limited medical provider and the pharmacy that there's no fraud happening between the two. And there would need to be the reliance on a legitimate order being made, just like there is with prescriptions. Prescription fraud happens, potentially this is subject to abuse with fraud as well, because of how it would be set up. It relies heavily on the pharmacy to legitimately record those registrations in the system, and to help the patient with that, and to help the limited medical provider document it in the electronic verification system. Conditional card issuance while applicant waits for Department of Health to review and approve card application. So this sets up a 60-day period during which the Department of Health would have the time to review the card prior to doing the final issuance. But a conditional card will be issued and automated to be issued after the certification is recorded in the electronic verification system. So in our current process, there is this need for the state to review every single card before there's any type of issuance. This bill requires that we allow for a conditional card to be issued upon certification by the provider, and that gives the state time to review and approve the card application for the full renewal cycle of 6 months. So but this conditional card issuance will not apply to cases that must go to the Compassionate Use Board. So it will not apply to individuals under the age of 21 or individuals over the age of 21 that do not have a qualifying medical condition. So that's important to keep in mind. Collection of QMP medical clinic fee data in the electronic verification system and posting of the data on the Utah State Auditor's website. So one thing that we noticed in the industry that Senator Escamilla was very concerned about is just price gouging, the fees being charged by some of the medical clinics were pretty high, and that was a major concern. So she decided to amend the bill to require that all the QMPs / medical clinics, whatever fees they're charging, that ends up being that the cash that they take in on a visit, on an initial visit, that has to be reported to the Department of Health in the electronic verification system. And then there will be the plan is to have a geographic map. So all patients will be able to go to a website and they'll be able to see visually a snapshot of what prices are at different medical clinics throughout the state that do medical cannabis recommendations. And we know that that is just one factor that a patient considers. Some providers might have a very good reason to charge more than others because they spend more time, right?
Okay, Cyril.
Anyway, a medical cannabis component. Also, this is just a repeat about the controlled substance education that will be required. So that gives you just a summary of those two bills. Are there any questions?
So there were no
Yeah.
changes in qualifying conditions?
There was no change to the list of qualifying conditions. That has remained the same.
I have a question, Rich.
Yeah.
Couple of clarifications. In 192, in the original writing, there was a line that would require that dispensing info would be included in the DOPL database,
Uh-huh.
and pharmacies would be allowed to provide educational material. I have some questions about 170, but did those get dropped?
No, both of those are in there. So the first amendment you mentioned is the first item, medical cannabis products.
Oh, sorry,
Yeah.
got it.
Yeah, and then the second issue is that the medical cannabis pharmacy, it's been clarified that they can distribute educational material without charging the patient for it. The former law stated that they could sell educational material, but the law is also very prescriptive about what they can and can't do. And under the former law, literally, if we interpret it really strictly, they could not even they could not even give out educational material. And so we worked with the industry. We thought that needs to change. They should be able to distribute educational material as long as it meets certain standards.
Okay.
Right? So we have worked with the Utah Department of Agriculture and Food on standards that we feel comfortable with already. And under this SB 192, what we're going to do is we will publish those standards in rule, and then whatever educational material is made available in the pharmacy must comply with those standards. So, and the standards, we were able to evaluate standards in other states that have medical only programs, and we learned a lot from what they put into place. And we believe we've found a good medium. We've already circulated that language with the industry, and we feel like we've got some good input. So that's our plan to incorporate that.
And then just one, thanks, Rich. And one clarification on 170. Is it the language is still there that allows a limited medical provider to own or be employed by a pharmacy or courier or the industry, basically?
Yeah. So
That's
I
still
believe
allowed.
there's language that there's there's language in there, I'll share it with you after the meeting, that you would, I think we could argue that it limits that. But then there's other language that I feel like makes it unclear. And I need to review this with our attorney, but I believe we can make an argument that there's language that would limit it and would restrict it, but I need to confirm that with our attorney before I conclude that for sure. So I'm happy to share that information with you later. I do remember, of course, you had brought up that concern, and we had informed the legislative attorney about it. And I need to confirm how that surfaced in the end of the bill. So I can do that.
What was the motivation for that? That is a troubling provision to me.
Well, you're talking about the ability for a limited medical provider to be employed.
Well, to recommend up to 15 patients without registering with the Utah Department of Health or using the EVS.
Yeah.
It seems to me you could drive a train through that. That's very broad language.
Yeah, keep in mind, this language is just a summary of the actual bill. So I'm like giving you the very high level, right? Of course. So one thing to keep in mind is that there's arguments for and against this, obviously. The legislature decided on the policy to allow this under Senator Escamilla's sponsorship in this bill. But one thing that we know is also in the bill is that every controlled substance prescriber must complete controlled substance education every 2 years. Now, what we understand, sometimes stuff you learn in those courses, it goes, one in one side and out the next, as far as sometimes for courses like that. I'm hopeful that with the amendment of that course, it's required under the law to be amended such that there's a medical cannabis component. So that would be an opportunity for us to, I think, educate controlled substance prescribers all throughout the state of Utah, all 16,000 of them or so, that they are required, not required, but they are just made aware of some of the significant contraindications like pregnancy or others that they may not be aware of about marijuana. So that sets a very broad, and I understand a very low denominator for education about it, but at the very least it's there. And so it's not, I think, the best case, but it's better than nothing, right? And so you can speak if you want to, if you have more questions about the basis of the policy. I think it'd be a good idea for you to reach out to Representative Ward. He, I think, is someone that is more versed about this than other legislators about this particular amendment.
Okay, with that, Rich, I'm gonna re-grab the reins of the meeting because we've got 8 minutes until I want to turn this over to public comment, and even that's very limited at that point. But obviously, this has been a pretty dynamic couple hours with a lot of stuff. Reshma, can you share my screen?
You should be able to share your screen. Do you see the share screen green button? There you go.
Yeah, let me go to that and see if I can show you this one quick slide here. Okay. Are you, Rich, can you let me know, or Reshma, are you seeing this?
We are not seeing it.
Let me figure out why not. Share screen. How about now?
Yes.
You are, okay, good. This is sort of where we're at. First quarter, end of Q1 2021. This is what the sort of our work product over the last year, 2020, up through to current time with the conditions we've reviewed. chronic pain, multiple sclerosis, autism is we're in process, PTSD, and then the non-qualified conditions we reviewed, anxiety at the request of someone, and then opioid use disorder, at the request of some legislators or others with interest. So we have this whole list of other conditions that we should proceed on a monthly basis, or at least every other month basis, to sort of dig deep and see where the evidence lies. And if anybody, does anybody on the board have a burning interest in pursuing one of these? If so, that'd be great. We'd applaud that. If not, I would be happy to reach out to my colleagues at the Huntsman and see if we can get a review of the role of cannabinoids, what we understand in terms of best current evidence, role of cannabinoids and cannabis in cancer, which would I'd roll up into, as well as into cancer and chemotherapy-induced nausea and vomiting, as well as I talked about it a bit with regards to chronic pain, but maybe sort of to review, re-review cancer pain conditions and the use of cannabis and cannabinoids. So if I don't hear an objection to that, I'll reach out and see if we can get that organized for the next, maybe by May, give these guys a chance to review that literature and see if I can beg, borrow, and steal some of their time to do so. It's sort of a tacit approval for that direction. Okay, and
Hey, Perry, this is
yeah.
Ed Wright.
Yeah.
I think it would be really, I mean, I'm looking down to the list of the one illness that in my mind is really complicated, and if we get it wrong, it can sometimes be lethal, is epilepsy. And to me, that one, I think it'd be really good to take a deep dive on that one and have some expertise from University of Utah or someplace else that as far as using CBD versus medical cannabis preparations for treatment of epilepsy. To me, it's very complicated, and I think it'd be helpful to have some input from somebody on that.
Absolutely. Does anybody have a contact in the in neurology or the epileptology arena if they want to reach out? It's not it's not my immediate network, but
I mean, specifically along the lines of, like a pediatric neurologist person who might have some expertise in this area. I mean, obviously
yeah. I mean, obviously, yeah, we want somebody who treats a lot of epilepsy patients and who struggles with this, just like we did with Dr. Bill. Okay, I will take that recommendation, Ed, and I'll dig deep into who has those qualifications and credentials to do that. And I'll see.
Terry, I can help you there. I don't know if anyone knows Dr. Fran Few up at the University of Utah. He's
okay. You want to reach out then, Rich, and explain what we're doing? That'd be
I know
great.
him from the hemp extract registration program, and I can reach out to Dr. Few. I think he's I know he's a neurologist that I believe is still there that has done some research on it.
I wonder
Great.
if Deb Builder could make some suggestions as well, especially in the pediatric realm, because the home program includes a lot of neurologists.
Yeah.
And so just a thought.
There's
And
views-
the University of Utah was involved in the clinical trials of Epidiolex or PLX, the CBD. They got FDA approved for this indication. So I know that there are people up there, it's just not within my network. So Rich, if you can reach out and
Sure.
maybe copy Deb on that, Debbie, and see if she knows anybody. And then, and one person there will know another. So let's see what we can drum up. So Ed, thanks for that. And the rest of you all, kind of keeping your eyes on this list and think about if you haven't so far been involved in this, not that you have to do it so much, but within your network of people and the kind of patients you treat. So we'll maybe proceed with epilepsy and cancer. And I'm hoping we can get through the rest of these or most of them in 2021, at least as a first review. Now, my next, gosh, I've got 1 minute for this, so let me talk really fast. My proposal, which I wanted to actually have more discussion on, I think it's time that we start thinking towards the fall when it is safe to get together in groups again, hopefully, to actually have a state of the art, state of the science meeting, a day-long meeting to review where we're at with this program. The Center for, so sponsored really by the Center for Medical Cannabis and the Department of Health. And over the next few months, call for submissions for plenary sessions by folks within the program, without the program, people who are in pharmacy, who are on the front lines of this, qualified providers, anybody who wants to really take responsibility to creating a 20 or 30-minute plenary session that reviews what we know in various domains of this program, including well, I think we'll want a review of where we're at with our survey, with where we are with our database and trying to build a sort of very responsible evidence-based program here, but really help sort of sort out the wheat from the chaff in terms of what's known versus what's aspirational and what's anecdotal and so on. So a state of the art, state of the science, and I would suggest that if it's a one-day deal, we do it somewhere we don't have to pay money. It's where we can get space at the university or the health department or somewhere we can beg, borrow, and steal enough space, and make this an available meeting and CE with CEs attached to it. I can do that through the university or through the health department, and make this a really a meaningful day of where are we at with our program and with the intersection of what we know and don't know about cannabis and cannabinoids. Some of the discussion today really speaks to what do we know about the pharmacology and how might that move forward with what we know. How do we separate out different cannabinoid effects from different terpenoids and the many constituents? When do we get to the point we can measure those and look and understand the interactions? A lot of unknown questions, but I think it would be of great interest to a lot of different people. Obviously something we don't need to charge for. Hopefully with our various networks with CEs and so forth, we can get that accomplished with maybe some co-sponsorships by, and in fact, including where we stand with legal and issues around the law, and perhaps with policy, and maybe get someone like Senator Vickers to give a sort of a talk about where the legislature stands and what their thinking is about moving forward different types of policies and bills and so forth. Anyway, in the inception form, I just wanted to get sort of a sense of the board, something to move towards, or are we ready yet to think about that in 6 months, or are we premature? Or what? I'm certainly willing to do some of the legwork. I've put meetings together before, and it's a pain in the you-know-what, but it's worth it if people walk away smarter and more capable and more informed. Sorry, that was more than a minute.
Yeah, this is Ed Red. I just want to state that I attended one of these meetings in Portland, Oregon about 3 years ago, and it was really helpful for people just walking into the realm of, the University of Oregon Health Science University put together a program kind of like what you're talking about, Perry, and it was really helpful to people who, for me especially, to kind of get an idea where we are and what we know and don't know. And that, I don't know, I'm in favor of doing this. I just want to put my 2 bits in there.
Okay. Anyone else want to weigh in quickly? All right, with not hearing objections, I'll start formulating this and talking about this with Rich and see if we can actually, and Reshma, think if we can move the mountains to do this. We'll see. All right, so I've got some homework. Let me turn this over. I apologize. We will go over if there are comments that need to be voiced by the public. I don't want to cut that short. You know, we want to be transparent here. So any comments from non-board, non-Department of Health attendees here? Hands raised or not? Reshma, do you see anybody?
While we wait for that, Perry, just one reminder is I think Reshma had sent an information about a course that the Maryland Medical Society is putting on. As you know, Maryland is one of our medical only friends out there, and they are putting together a webinar that'll take place this Saturday. And it's a webinar, so anybody can do it, of course, if you pay the fee. So anyway, if any of you are interested, contact Reshma. She has information about it. And it's something similar to what you're describing, what we want to do here in Utah and host in person in the future. And we're certainly just wanting to learn more from these other states like Maryland. So it's just an opportunity to learn more about what the latest is on research.
Thanks, Rich. All right, it is exactly, I can't believe it, 11 a.m. Mountain Time. So I'll drop the gavel on this meeting. Thanks. That was a very stimulating couple of hours. I really appreciate everybody's either involvement on the chat. Certainly Deborah Builder. Once again, welcome to Dr. Woolsey, and not goodbye to Dr. Babbitts, but see you later, alligator, to him. So everybody take good care, best of health, and see you in another month.
Thanks, Perry. Thanks, everybody.
Thank you.